From the beautiful Finger Lakes region of upstate New York, this is the Dental Lighthouse Podcast. We take questions from anyone in the dental profession and discuss what it takes to win not only in dentistry, but in life. Business, leadership, relationships, parenting, health and wellness, money management, nothing is off limits on the Dental Lighthouse Podcast. I'm Jason Tanoory, your host, and have over 20 years of experience to pull from. Learn from my mistakes and let me help you collapse time so you can become the best version of yourself. Yo, welcome back. Dr. Jason here at Dental Lighthouse Podcast, and I am super excited for our guest today. It's Miss Rachel Wall from Inspired Hygiene. For those of you guys that don't know Rachel, she is infamous amongst the dental community for helping hygiene departments become the best versions of themselves. She's helped me personally. She's helped many groups that I'm familiar with. And she's just a wealth of knowledge. And selfishly, I'm excited to take a lot of that wisdom and knowledge from her and bring it back to my own group. And I also hope that the conversation today can inspire you to make you and your hygiene department that much better. Rachel, welcome to the Dental Lighthouse Podcast.
Thank you. I'm happy to be here.
I'm happy to have you. I'm just going to read a little bit for those 2 or 3 people across the country who don't know who Rachel is. Just a little bit of a bio here. Rachel Wall, RDHBS, inspires dentists and their teams to build highly productive hygiene departments by implementing systems for high quality periodontal care, enrolling restorative care through hygiene, letting go of negative mindsets and old beliefs while managing the logistics of a high-performance hygiene department. Drawing from her 25 plus years of experience as a hygienist and practice coach, Rachel delivers to-the-point, interactive presentations in the U.S. and internationally. Her energetic teaching style, coupled with a workshop environment, creates a learning space where dentists and their teams are inspired to reach more, creating a strong return on hygiene for their patients, providers, and practice. Wow, that's impressive, Rachel. Thank you so much for being on the show.
I like that. It's been a while since I've heard that.
They've wordsmithed it correctly. So again, very appreciative for you being on the show. How are you doing?
I'm doing great. Thank you.
So, as we talked about before we hit the record button, I personally don't have any agenda here. I don't want to talk about this specific thing or that specific thing. I'd love to just do an open-ended, let's have a conversation, let's have a dialogue about some of the pain points that I hear from my listeners on a regular basis, that I hear from my hygienists on a regular basis, all in an attempt to collapse time for people and help them become the best version of themselves. Are you okay with that?
I am ready, willing, and eager to get going. Yes.
Cool. So let's just start from the top. One of the things that I routinely hear amongst my hygienists, because we're a fairly large group, is a overall lack of calibration between multiple providers, doctors and hygienists, but specifically hygienists. And I used to think it was something as easy as you're holding the probe the wrong way, or you're doing something incorrect with managing pocket depth. But the more educated I get in this space, the more I realize there's so much more to it, to coming up with, let's call it an official diagnosis. So I would just love to hear your thoughts on what are some of the best ways that an office that has 2, 3, 4 hygienists can ultimately get calibrated so the patient is getting a similar experience no matter who they see.
Yeah, this is perfect. I just actually read an article for ADOM about this, and I would say one of the first steps is developing a clear and written hygiene standard of care. Now, what this doesn't mean is the dentist sitting in her office, scribbling down all the things that they want and then handing it over as this is our standard of care. It really is most impactful when it is a collaborative approach. And also when there are facts presented to support what it is that you're trying to get to with regards to the standard of care. So what I mean by that is, if, I just heard from a dentist this week, actually, I've tried to talk to my hygienist about how frequently we're doing a period charting or what we're recording, right? And I'm still just getting pocket depths. They're not putting bleeding in the chart. They're not putting recession in the chart. And we've talked about this over and over and over. And then the question is, do you have this as a written standard of care? And the answer is typically no. We do these virtual growth forums. This is essentially a webinar that we do every couple of months that's completely free and just on some hot topic. And we did a survey recently in one of these. And the question was, do you have in your practice a written hygiene standard of care that's followed by all the hygienists? And 67% of the attendees said no. So I think that's pretty representative of most practices. It's just something maybe that you haven't gotten to. But that's the starting point. And so if there is, it starts with the diagnostics. What are the diagnostic screening things that you're expecting your hygiene team to do on a regular basis? What is the frequency that it needs to be done? And I go to several different sources. I go to the AAP, the American Academy of Periodontology. I actually just have sitting next to me, for those that are watching, this giant perio textbook that I buy every few years, right? Because I want to know, like, what is current and how do I back this up? It's not just coming from Rachel Wall. It needs to come from multiple credible sources. So that would be, I would say, the number one thing that we see really move the needle with our clients is when we help them facilitate creating that standard of care and having it backed by credible sources so that the hygienists feel like, okay, all right, well, then if that's what the standard is, yes, we need to be doing that. Now, once that's created and everybody agrees on it, and this is a process where the hygienists are able to poke holes in that standard of care and talk through some of the nuances of it, right? Because we work with human beings, like everything in our world is nuanced from, what are the, medical risk factors this patient has versus what's their dental history. Have they lost bone, but they're actually healthy? Like, we're not going to put all those patients into treatment. So there's all those things that we talk about. And then once you have something that everybody agrees to, then really looking at, all right, then what are our obstacles to actually implementing this standard of care? And then you're going to come up with a whole nother list of things to work through. So it's never just one thing, right? It's never just, all right, let's agree that we're going to do a complete perio charting once a year. It's, okay, that's great, but, when my patients are late, what do I do? Because you're going to get mad if I don't have production in this appointment. And I really need to do the perio chart because that's what we agreed to. You see where I'm going with that. I mean, you work with a group, all the rabbit holes that we go down to solve issues and solve them for the long term.
Yeah.
That'd be my first part one of the answer. Yeah.
Yeah, I love that. And to your point, there's so many subtle nuances in there where in theory we could have what we want to accomplish, but then life gets in the way. And,
Yep.
We've always joked that dentistry would be easy if it wasn't for the patients.
Right.
But no, you're 100% right. So if I'm hearing you correctly, just to kind of summarize as we have this conversation, just a collaborative agreement amongst the hygienists and the doctors on, what defines specific levels of diagnosis? What defines, and we don't need to get fancy and talk about, grading, classifications and stuff like that, but just as a general overview, what defines gingivitis, what defines certain levels of periodontal, and just, what do we need to do to ultimately come to that diagnosis? So I agree 100% with that. And I also agree that when life gets in the way and we don't have time to go through the ideal set of diagnostics to come up with that diagnosis, how do we pivot and how do we handle that? Is that a good summary of what you're saying?
Yes, and what are the absolute critical pieces that you need to have so the team at least has an idea of how to triage, right? So when sometimes a patient shows up and they need everything, right? We have an idea that they have sleep apnea, they've got decay everywhere, they have periodontal disease, and they're looking to whiten their teeth, right?
Yeah.
So how do we know where where to start with that? And the standard of care is very helpful with that because we have said, hey, look, if anything, these are the core things that we have to have. Also legally, right? There's things that we need to have legally. I don't use that term a lot, but if you have patients that are coming in your practice for care and there are certain very core basic diagnostic items that you must have in order to get to the next step of treatment and they're not there, then that could be a problem. So,
Right.
For example, we're treating this patient with periodontal therapy, but we don't have diagnostic x-rays that show the bone level. That's a problem.
Right.
And the standard of care can identify what some of those core things are. Yes, so that's super helpful. And then I think that kind of flows into what we call case review, which can focus on the perio, the restorative, all the other, I will say, specialty type areas that you might have in your practice to really work with your team on calibrating that treatment philosophy, so that if you have multiple doctors in your organization, that the team that's expected to tee up treatment for those doctors has that those doctors have generally a similar standard of care for themselves.
Yeah, no doubt, no doubt. So if the first domino that ultimately needs to fall is a collaboration and then ultimately a calibration on the diagnostics involved with making the correct diagnosis, in my opinion, or in my lived experience, the next pillar that needs to, or domino that needs to be fall is the presentation to the patient.
Yeah.
And we could certainly go down a rabbit hole talking about the oral systemic connection, and that could be a great podcast for another time. I feel like most of my listeners are pretty up to date on that connection. What we find as a pain point is knowing what the patient needs, having the correct diagnosis, and having the patient not receptive to ideal treatment, or maybe there's a lack of perceived value with the proposed treatment. How are you coaching your clients to navigate that dilemma?
Okay, so the first thing we coach them to do is set themselves up for success before it's time to have that presentation conversation. So when they're asking their patients about medical history, rather than saying, has anything changed, right, which is a yes or no answer, saying, when was the last time you, had a visit with your physician? How did that go? Is this still current? Looking at their current medical history, are these still the medications that you're taking? So having more of an open-ended conversation, because sometimes patients are going to drop things in your lap, right? Like, oh my gosh, yes, my sister was just diagnosed with diabetes, and I have a visit with my physician coming up soon because I'm really curious where I stand with that. Or, my doctor just added a second blood pressure medication to my regimen. Asking diabetic patients, what was your last HbA1c? It gives you a glimpse into not only what's just going on in their mouth, but what's going on in their whole body, and how might that influence the diagnosis and the treatment and your conversation with the patient. Okay, so that's one piece of it. The next piece is we teach something called the 3 Ps of perio enrollment, which is the first P is prepping the patient. So it could be something as similar as, Jason, the next step in the exam today is going to be a thorough evaluation of your gums and the bone that supports your teeth. You're going to hear me call it a lot of numbers. 1 to 3 is typically normal, and healthy gums don't bleed. So now the patient has an objective benchmark with which to then measure themselves against. And then they measure themselves against that when the hygienist is calling out those numbers, right? Whether they're doing it themselves or they've got an assistant or they're using voice charting. And then the patient starts to process that as they're doing that. And so rather than collecting all of this information in silence and then dropping the bomb in the last 15 minutes of the appointment, they're really bringing the patient alongside them and allowing the patients even a small window into information so that they're beginning to diagnose themselves. And then when we get to the presentation piece, then we can go back to say, okay, so you heard this. That indicates that you have active infection in these areas. And the good news is that it's localized and we can treat it localized. We can treat this non-surgically. And I'm concerned about this because you shared with me that your sister has diabetes, you're going to get evaluated. And I know for the last 5 times I've seen you, we've talked about bleeding and nothing's getting any better. It's time to do something different. So Part of the success is the setup before the presentation conversation so that the patient has some idea of what to look out for. And this, again, is not happening at the tail end of the visit when the patient just thinks, oh, everything must be going, I mean, she's doing everything exactly the way that she normally does, or he normally does. So everything must be going fine, and I'm going to be out of here in a few minutes. And then all of a sudden it's like, boom, doctor comes in, well, actually, patient has periodontal disease. So it's much better when that diagnostic information is collected in the front end and then the conversation is had right away.
Yeah, I love it. I mean, you're just bringing me back, and I'm aging myself here, but to the classic Bob Barkley co-diagnosis mindset of, to your point, not just slapping the patient across the face at the very end of this data collection, but, kind of stringing them along the entire way and calling out probing depths, calling out bleeding upon probing. And I love the statement, healthy gums don't bleed. I have a couple of hygienists that actually want to put that on a t-shirt and just, walk around town with something like that. Let's do it. Yeah. Because you're right. Right. And it's having, in my opinion, it's having the courage to not be confrontational, but when a patient says something like, well, my gums have always bled, or this has always been my situation. If you're a hygienist that's recently out of school, that can be a really uncomfortable conversation to have. But as you develop some courage over time and you're ultimately positioned to do what's in the patient's best interest, you can have a conversation. Well, we need to do something different because this level of inflammation, this level of infection, it's not healthy for you. And I think your point about the host for lack of a better term, is spot on. So someone that's 40 years old, very healthy, that has a third of their mouth bleeding is certainly one situation compared to someone that's a third of their mouth bleeding, but's pre-diabetic, but is hypertensive,
Yes.
borderline high cholesterol. It's a completely different animal.
Yes.
So empowering our hygienists to actually be clinicians and not robots to use their mind to figure out what's in the patient's best interest, I think is a super valuable lesson that you're communicating here. So thank you very much.
Absolutely. I think that is the number one thing that we really teach with the hygienists in our client practices is critical thinking. So everybody wants the cookie cutter, just tell me what to do when. And the standard of care sets some of those parameters, but at some point you have to think about this patient. And so we want them to learn how to think about the patients, not in an effort to try to not present treatment, right? Well, they're really healthy, so maybe I don't have to do this. Maybe I don't have to present treatment today. No, it's more thinking of what is the most proactive thing I can do that's going to reduce their risk for some significant health event, or even just reduce their risk from walking around with chronic inflammation all the time.
Right.
Like we will never know. I mean, that's not true. It's not often that we know that our care from a periodontal therapy standpoint, prevented some health impact, or even just our care in general. I think with blood pressure, that's an example of when we're consistent with taking blood pressure. There are those patients that walk in and say, oh my gosh, I went to my doctor because you alerted me to this, and the doctor said, I'm really glad you got in because you're in a risky state. For those patients, the switch flips and they start to see their dental team as their healthcare team. For other patients, it's on us to drip that seed all the time. And then eventually many of them will come to that realization. But, it's the oral cancer diagnosis, the blood pressure screening, the sleep apnea, and the patient feels like a new person, right? Those are the things that then flip the switch for them to see you differently. But it really is up to us. It's our responsibility to change that perception because of how we behave as providers.
Love it. So just so much wisdom there, Rachel. And let's start to unpack a little bit of it. I have found that as we've tried to change the mindset of our hygienists over the last couple of years, it's starting to gain traction. The classic, the flywheel of momentum is starting to move. And what I'm finding personally is for new patients, the conversation is very easy, right? These are the diagnostics. This is the diagnosis. This is your medical history. And they, being the clinicians that they are, the experts that they are, they can put it all together and they could spit out a diagnosis and a treatment plan. And it's an easy conversation for them to have.
Yeah.
Where we still struggle, where the hygienists have some pain points, is the Mrs. Jones that they've been seeing for 10 years, constantly bleeding. And they, meaning the hygienists, almost feel like this sense of responsibility for perhaps mismanagement of the care for the last 10 years. And trying to coach my hygienists up to get over that mindset has been a struggle, where the hygienists are hesitant to have uncomfortable conversations with Mrs. Jones based on how she's presenting today. So I would love to understand how you coach up hygienists to best have that conversation with someone that they've been seeing on a regular basis, telling Mrs. Jones everything's fine, or Mrs. Jones just bleeds, it's normal for her. Now that they've been educated, now that the hygienists have been educated to a new standard, how do we have those conversations?
Yeah, that's one of the top, I would say, 3 questions that we get. And it's the thing that the hygienists are often most nervous about, because they have relationships with these people, right? With the new patients, okay, well, you came in, obviously you want to know what's going on, so I'm going to tell you, right? But it's those people, they have relationships. And the goal is to switch the mindset from, oh my gosh, I can't tell them this, to how can I can't not tell them. Because I have this relationship, I owe it to them to be honest and to share with them what I'm observing, because this is their health that we're talking about. And so, we do the best we can with the information that we have. And when we have better information, then we can do better. And there's all, the term we now know goes a long way, because when we learn something new, we now know that this type of inflammation can be linked to, a greater risk for heart attack, stroke, and type 2 diabetes. And so that's a first step, is really shifting that thinking of we can't not tell our patients if they have chronic inflammation. One of the hacks I'll say that we teach is with those patients is having the hygienist go back and look in the treatment notes, whether they're the patient, the provider that treated them, or it was somebody else, in the group. Go back and look at those clinical notes. You're likely going to see signs of where seeds were planted in the past about this. So whether it is, we recommended a Sonicare, we reviewed flossing again with the patient, we recommend the patient come more frequently for a prophy. Whatever those seeds are, there's likely evidence of those in the clinical notes. So go back and read that, because it helps the hygienist understand, okay, so actually we have talked about this in the past. We just haven't recommended any different type of treatment. And so then we have to do our diagnosis today, right? We have to set this up, and we have to include the patient, and then we have to say, Ms. Jones, here's what I've noticed. And looking back at your chart, I know we've talked about this, or, you met with Stacy, the hygienist that you'd seen before, and she talked to you about this. And what we're noticing is that, your body's not responding the way we had hoped. It's time to do something different. Now, you can talk about how we've been as conservative as, as possible up to this point, but you have chronic inflammation. That's not healthy for you, particularly when you have these other inflammatory conditions. And so, your body's not responded the way we had hoped to these interventions. It's time to do something different and go from there. So it's not discounting that what you've done in the past hasn't worked. I wouldn't say it didn't work. I wouldn't say, you're just not doing your home care. And, we've talked about that. Like, don't shame the patient. Just think about it. If you went to your physician and they said, your blood pressure's high, but you mentioned you just started exercising and you're eating better and all those things. Let's track this, come back in 3 months. And then if it's not any better, we'll have a different conversation. And then you get there and they say, you know what, it's not healthy for you to have this even chronic, high blood pressure. I know you've worked to do that, but for some reason your body's not responding to that the way we had hoped. It's time to do something different, and we're recommending X, whether it's a medication or some other regimen. It's like, I don't think the doctors feel bad when they tell somebody they have high blood pressure. It is what it is. I'm not sure
Yeah.
if it's like the beat down that we get in dental hygiene school, as I'm sure you probably got in dental school, or where that comes from. But we have very close relationships with patients. I mean, you see them more frequently than they see their physician, but it's really switching that from, oh my gosh, I can't tell this person, to I can't not tell them. And then it's their decision what they do about it.
I love that. And I love the phrase "we now know" because it just creates authority, and it creates like a fresh start, a fresh sense of,
Yeah,
what the newest literature is telling us.
right. We're staying on top of it.
Yeah, I love that. And I love the doctor analogy too. And I've told my doctors and my hygienists that when I was younger in practice, I had such a fear of rejection.
Hmm.
I was a people pleaser. I just wanted the patients to say yes, to the point where I was treatment planning things in a roundabout way where I knew they would say yes, right? So the
Right.
typical big cavity, I can fill that because I knew they'd say yes to a filling,
Yeah.
as opposed to the ideal treatment of a crown, right? So I see the same thing in hygiene where, yes, I can do another bloody prophy because I know that I'll keep our relationship cordial and friendly, but what you really need is, periodontal therapy or something along those lines. And I've tried to use analogies like this with my hygienists, and one that I've developed over the last year or so is, we have this perspective that patients either can't afford or don't value what we're trying to provide for them, and for that reason, we don't even present
Hmm.
ideal treatment. So
Make decisions for them.
yeah,
And
no
we really
question.
don't, it's not our place.
Yeah, 100%. And I try to, the analogy that I use with my team is, when this 65, 70-year-old lady brings her car to the mechanic, and the mechanic does the review on the car and sees that there's four bald tires, do you think the mechanic's saying to himself, I really don't want to tell Mrs. Jones that she needs four new tires because she can't afford it, or I know she doesn't really value good traction on her tires, so I'm just not going to say anything.
Hmm.
Like that's preposterous. There's no way that they would do
Right.
that, right? So why are we in a much more important position? Why are we deciding what we will and will not share with the patient because we've already decided in our own minds what we think they value or what they're going to agree to? So it's frustrating, but at the same time, I see it as a great opportunity to raise up our hygiene
Yes.
and our doctors, to ultimately do what the patients, what's in the patient's best interest.
Yes. I love that analogy because think about it is, let's say that woman, let's say she's 65 years old, let's say she's 75 years old and she's driving a car with bald tires. What happens when one of those tires pops and she's on the interstate? Or what happens when a deer runs out in front of her and she has to correct and she doesn't have traction on the road and she gets in a wreck? I mean, it's a perfect parallel for what's happening. That mechanic doesn't know her driving style. He doesn't know the driving conditions. He doesn't know where she's going in the next, few months unless she tells him. But same with us. Like, we don't know what's going on in our patients' bodies. We don't know that sometimes there's a lot of things our patients don't report to us, right? I mean,
Amen.
yeah, yeah. So just imagine all the things they tell you, there's probably twice as much that they're not telling you. So that's a very good analogy because right around the corner from them could be a major health event, and them being healthy and not having even just that one layer of chronic inflammation could be the difference in how long it takes them to heal from something like that. So
Yeah,
that's a very, very good analogy. And the other thing that you mentioned was the doctors have to be on the same page. So
right.
everybody has to be aligned with that standard of care so that, for a couple reasons. One is when the hygienist presents something to the patients, the doctors are backing up and they're not pulling the rug out from under. And also when the hygienists aren't presenting treatment, when the dentist sees like, shouldn't we be presenting treatment? That there's some accountability there in the form of coaching, right? Is,
Yeah.
okay, I've noticed this the last, week. there's been these three specific patients, right? Not just a general, you're not following the standard of care. It's like, here are three specific examples. Where's the holdup here? Where are you feeling blocked from presenting ideal treatment? And how can I help?
I love it. I think constant edification from the hygienist to the doctor and vice versa is paramount. We're constantly talking about how the doctor should really be the second opinion. The hygienist gives their recommendation, and then the doctor ultimately backs it up. And then at that point, the patient's always typically on board with the recommendation because the doctor backed it up. The worst thing ever is to have the hygienist not say anything, and then the doctor makes a recommendation, and then the doctor leaves the room, and now there's this suspect. Do I trust what he said? And all that needed to happen was for the hygienist to start the conversation ahead of time. Yeah.
Right. For sure.
So I want to be super respectful of your time. So, and I could talk to you all day, just selfishly, just going to make me a better clinician and a better leader of my hygienist. So we'll have to perhaps get on another call. But in closing, I would just love to get your kind of quick perspective on treatment modalities that are new and upcoming. We're beyond. The scaling and root planing is the only treatment modality. There's a lot of clear science to suggest that it's biofilm, not tartar, that's the cause of periodontal. So with that backdrop, what are the 2 or 3 things that you're really excited about in the treatment of gingival inflammation, periodontal infection?
There are a lot. I will say that I continue to be excited about PerioProtect. PerioProtect is a proprietary tray system, so made in a specific lab, that has a seal that pushes a peroxide solution, holds it in the sulcus. And I've seen results with that personally as a hygienist. I've seen results with it in my family. I've seen results with our clients, and not just with periodontal patients, but gingivitis patients as well, patients that, have chronic gingivitis. There's also been some research out around that product where in the very past, it was maybe the compliance was difficult because it was, hey, you have to wear this 3 times a day for 20 minutes a day or whatever that was. There has been some research showing that even wearing it once a day for 15 or 20 minutes can make a difference on the biofilm. And so it just helps the patients it helps them manage the biofilm at home between their visits. I'll give an example. I'm actually today, this afternoon, I'm going to pick up my mother. My mother has advanced stage Alzheimer's disease. She's still well enough that she can travel between my home and my brother's home. But one of the ways that we manage her long-term periodontal risk is with PerioProtect. When she's with me, I do her home care. She has a personal dental hygienist. So, it's a little different than when she's with my brother. He does the best that he can.
Yeah.
But myself and the hygienist that we kind of co-care for her are always amazed at how well, we're keeping that periodontal disease at bay. And that's just an example. So I think that's a great option. There are, there's evidence with lasers. There's evidence with, I was just talking with the team, and one of our coaches actually is teaching a biologic hygiene mini residency coming up in January. And, she's going to talk some about ozone with one of our clients and even using ozonated water to help, oxygenate the sulcus, which is also what the peroxide does. There's a relatively new product out called HybenX, which is a desiccation. It's called desiccation shock therapy. So it desiccates calculus and also kills bacteria. It does not have necessarily a time released effect like a rusted might, but it kills bacteria on contact. It's easy to apply. It's affordable. It's something that can be used in conjunction with scaling and root planing. And there's always, more things coming out. I think Curodont is not perio related necessarily, but that's really promising, and something that can be placed by hygienists and assistants in most states. So that's a pretty neat product as well. There's so many things that are, there's more. I've been in dentistry since 1989 is when I started hygiene school. And just even the last 5 to 7 years, the amount of technology that's been out is
Right.
remarkable.
Yeah, it's an
Yeah.
exciting time for sure. It's an
Yeah,
exciting time for sure.
it is. So I think exploring all of those things and figuring out what fits best with the philosophies and experience of the dentist, the clinical leader. Everybody requires a different level of evidence right before they try something. Some people really want to pour through all the research. Some say, hey, let's do a lunch and learn. Let's give it a try. So everybody, we just encourage our clients to explore things that will enhance non-surgical periodontal therapy because there are things out there and we have things that we recommend, but we don't have a, hey, you have to do this or you're not going to get results. Like it's really up to the individual team to decide what fits best for them. And then those things, once you make that decision, they should go into that standard of care. So, as adjunct services, and what are the thresholds in which you are going to recommend those things?
Right, right. That's awesome. I appreciate you unpacking that. And each one of those modalities, we could go down a huge rabbit hole, and maybe someday that we will. Rachel, just in closing, if any of our listeners, if your message really resonated with them and they'd like to learn more about you, what's the best way for them to get a hold of you?
So I want to share a resource with everybody, and then, yes, I will share that. So one resource we have on our website, so if you go to inspiredhygiene.com, there's a tab that says, I think it says resource guides, free resources, something like that. If you drop down, there's a standard of care worksheet that you can download. So
Okay.
that way you don't have to start from scratch. There's something that'll help you kind of get that process going. So that's available. And then you'll also see on the website, there is a link to book a discovery meeting. So that would be a great way to connect. And no pressure. If you just want to talk about what you're seeing in your hygiene department, how we might be able to help, we would love to connect with you that way. And then folks can also email us at clients@inspiredhygiene.com. So whatever feels like the best way to get in touch. We'd love to hear from anybody. But thank you. This has been great.
Awesome, Rachel. Thank you so much for the time and for the wisdom, and I'm looking forward to having you on the show again soon.
I look forward to it.
Ladies and gentlemen, Miss Rachel Wall.
Thank you. That wraps up another episode of the Dental Lighthouse Podcast. You have a choice today. Choose to be a lighthouse. Lighthouses are powerful and steadfast. They are beacons of light for others to reference when life gets turbulent. Go out into the world today and become a lighthouse for someone. Give more than you get. True joy comes from serving others. Start today. I'm Jason Tanoory, your host. Thank you for listening to the Dental Lighthouse Podcast. For more information, podcast show notes, or links to anything that we have discussed today, please check out our website, thedentallighthouse.com. We would love to hear from you. If you would like to get on the show, please email us at podcast@thedentallighthouse.com.